Okay. Good afternoon. I am Chris Knutsen. I'm one of the founders of Emergency EMS Medicine Live, and today is going to be our fourth webinar. If this will work. There we go. So just a quick overview for those who haven't seen this before. Our purpose here is to create a social group to discuss EMS medical issues for both community and academic EMS physicians and also for EMS providers. Hope to provide some decent information, maybe at some point some board prep. We have Dr. Martin Gill presenting in 2 months with a good topic for that. Also a chance for us to see each other, or at least you to see me right now, and bring together all of our skills to hopefully get outside presenters from outside of New York State to give them more information. Obviously, there's myself. I'm one of the course directors, Derek Cooney, who I'm not sure is here yet. We'll look for him. And Brian Clemency out of SUNY Buffalo, who had this idea years ago, and we're glad to have it working now. During the presentation, we're going to have everyone being muted just to keep things more sane. If you do want to ask questions, go ahead and chat me. I have my chat window open, so I'll try to answer them as they pop up. I guess you can raise your hand in the virtual world of Zoom. You can try that. I haven't seen that yet, but you can go ahead and try. We are recording this, and we will post this to our website, which I'll share at the end. You can record from your side also, but it shouldn't be necessary. Try to keep questions to the end. Unmute yourself and ask any questions, or just message me and I'll answer them for you. If I don't see your chat question, go ahead and feel free to unmute yourself and just ask the group. Any problems, send me an email afterwards, right here on the screen. We've done very well with Zoom so far, so hopefully it'll continue on for us. Today the speaker is me. Keep it simple. I'm one of the professors here at SUNY Upstate. I did my fellowship training at the University of Pittsburgh and moved here about 5 years ago. And I'm involved in EMS education with my agencies, the region, with our paramedic program, work with our fellowship, and do response services as well. I'm just going to mute someone here. Okay. So today we're discussing excited delirium and sudden in-custody death for a very good reason I'll discuss later. There's different ways of describing what excited delirium is. It's kind of easy to say what it's not. It's not universally recognized. There is no medical diagnosis. Doctors and providers can't diagnose patients with excited delirium. There's no ICD-9 code. The American Medical Association does not recognize the term. It's not a psychiatric diagnosis. There's no DSM code that matches this as well. It is more of what it is more of a descriptive syndrome. Several groups do accept the term and use the term in their literature and especially with each other. Most of the physicians, medical examiners especially, EMS, police, and the press as well, also do use the term frequently. It's one of those things where you kind of know it, you see it, and you know it. So I'm going to provide an example from Appleton Police Department in, I think it was Wisconsin. Take a couple minutes. Maybe.
Autogaming 911.
Hi, something's wrong with my son. I'm in 1103 South Jefferson. I don't know whether he got on. He's 29. I don't know whether he got on or something. He's just, very strange.
Okay, is he in an ambulance? What are you reporting?
I don't know. He's just talking and talking and saying he's going to die, and he's making like he's on something. I don't know.
He keeps yelling because he's dying. Does he say anything else?
No, he just says, I'm dying, Mom, and he's sitting there naked. He certainly doesn't do that in front of his mother.
Here, hold on one second.
Hi, it's okay. It's okay.
As I'm not.
It's okay.
As I'm not. This is the last heartbeat.
It's okay. It's okay. I understand.
Isn't gonna die, but I'm going to. Isn't gonna die, but I'm going
You're
to.
okay.
Is I'm going to die.
9102 restrict traffic.
Beats.
But it's okay. What is his name? Tim?
Die.
Tim, we need to go to the hospital.
But I'm going to.
9102. Have Gold Cross come up to the address.
Because I'm not
1033 at
gonna
this
die,
point.
but I'm gonna hear the heartbeat.
Yeah.
Of
What's his
me
first name
saying,
again?
Oh, I'm going to die.
Tim.
But I'm going to lay down on the ground.
Can you lay down
as
for
I'm
me?
going to die, but
Tim.
I'm going to
Tim.
not, and you understand now. And isn't that fucking weird? But
9102.
It is nice he lays down by himself.
Advise Gold Cross. I believe we have an excited delirium case. I need them here. All right. We have the medics ready? Okay.
They're at the sideline.
All right. All right, let's move. Okay. All right, just relax. Okay, get the medics up. Let's get them on. See the medics strapped down to the.
I gotta grab my balls.
What?
But I gotta grab my balls one last time. It's okay. I can feel. I can hear this one. It's weird. Even though I'm okay, I'm gonna grab my balls.
Nobody's. Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax. Just, we're good.
Tim, you're right.
Tim, let's get him out of here.
Broke his back with a shovel. Broke his back with a shovel. Grab a shovel. We have a shovel in the backyard. Grab a shovel and poke his back out. No, grab a shovel. Poke.
You got it?
Yep. I don't want to kill you. You don't want to kill him. I don't want to kill him. Okay. I don't want to kill him. But
That is one of my favorite parts. At the very end, the gentleman says he's going to kill someone, and the medic calmly says, "You don't want to kill me," and the patient says, "I don't want to kill you." So, very, as we discussed later, a very ideal situation with intervening for a excited delirium and seeing the case. So there's three main components that kind of define excited delirium. Obviously, delirium, so altered mental status, fluctuating mental status, agitation, where you're super strong, and excitation. You kind of break it down even further. Obviously, people are combative, bizarre, not right, huge pain tolerance where you can hurt them and they can fight through it, and sweaty, hyperthermic, and with that, they're oftentimes naked, which is not fun for anyone. I'm going to pause for 1 second. I got to try to mute everyone, and hold on 1 second. Mute audio. If I miss you, try to mute yourself because there's some background. People are complaining of background noise. Tachycardic, tachypneic, very fast breathing, obviously paranoid, hallucinating, like attacking things, and don't listen to police. This is another example. This is Steve.
Sit down, man.
So obviously he's naked, not listening to verbal commands, not acting appropriately. This is not a real website. I've tried looking this up, and actually there's no don'tbelikesteve.com. You can hear the neighbors yelling at him to calm down. So she's pulling out pepper spray.
Come on, man.
Oops, sorry.
Sit down.
So to give him some space, starts destroying property. It's not compliant, super strong, pushing through police. A little slow-mo. They do often attack, well, I don't know if they often, there's been reports of people frequently attacking shiny objects, mirrors, glass, those kind of objects. Actually, some reports have been it's only about 10% of folks. They will damage property, but not always mirrors and shiny objects. Of course, with this, because they're in such a fight state, often hypothermic, develop metabolic acidosis, rhabdo, and eventually multi-system organ failure if they get worse enough. The past few years have not been the first time we've seen excited delirium. Apparently, it's been described back into the 1600s, called Bell's mania in the 1800s. Obviously, back in the 1800s, they didn't have medications to treat people with psychosis. So they were institutionalized for their safety and the safety of the folks around them, because there's no way to treat them. And there are reports of these people developing similar symptoms: agitation, hallucination, paranoia, a lot of fight symptoms. And in them, I'm not sure how they got the data, but they have about a 75% mortality. We're not sure what happened, if they were restrained, if they were fought with, but at least going back a ways, we know high death rate. Became more of a term in the 1980s and used again in 1998 with increasing use in literature and publications. What causes it? It seems to be pretty much agreed upon. Stimulant use and psychiatric disorders are most common, with some other medical or combination of these things. Obviously, the good old days, we used to have just cocaine, PCP, and crystal meth. Cocaine is very available. Charlie Sheen's been known to use it a couple of times. PCP, I'll be honest, where I trained in Pittsburgh, I never saw PCP until I came to Syracuse. Arriving in Syracuse, there was a Fish concert my second or third month here, and saw more PCP in one night that I've seen since then. So I look forward to Fish's return to the Syracuse area. And of course, methamphetamines being a common stimulant more so in the past decade or so. But now, beyond just the traditional drugs of abuse, we are seeing more and more of these designer stimulants or designer drugs, the synthetic cathinones and the synthetic marijuanas. I'm sure all of you at some point heard about bath salts for the first time. I remember when I first did a couple of years ago, was totally confused by why anyone would smoke bath salts from Bed Bath & Beyond or similar type places. And I'm sure there's a point in everyone's life when you realize that it's not from the mall, but from other bad places. So these are bath salts, but not the kind we're talking about today. Baths or synthetic cathinones, there is a natural cathinone called khat, found in East Africa and the Arabian Peninsula, very popular in Somalia and Yemen. It is typically, leaves are bunched up and put into the cheek to cause euphoria, alertness, and hallucinations. Not very good for your teeth, but does not look much different than Mike Dykstra from the Phillies years ago. Chemists got a hold of the khat in the early 1900s and began trying to find a more medical use for it. They were trying to use it as an antidepressant, antipsychotic, stimulant, and those similar type medications. There is actually one synthetic cathinone that's used for medical purposes, which is Wellbutrin, obviously used as antidepressant and smoking cessation therapy. The cathinones, you can see, are very similar to MDMA and amphetamines, and they're just defined by an oxygen group on their carbon train off of their carbon ring. And these are some of the more common synthetic cathinones, which are in distribution. But of course, there are dozens, or at least a dozen, if not more, different kind of synthetic cathinones, which each one changes their structure, changes their chemical properties, changes their effect on people, and also can have the effect of skirting the law. So if you have a different chemical structure that's not specifically outlawed, in some places it may not be illegal until the state changes the regulations. Most often it comes in little packages. There are dozens of names. Ivory Wave is common, Meow Meow, White Rush, and White Lady I've heard about personally. And they're usually little 3-gram packets of some sort of plant material sprayed with the synthetic cathinone. So you roll up into a joint, smoke it, and get the effect. There are some new kids in the block that are either coming or are here. At least in the Syracuse area, we've heard about Flocka and Gravel, which are new synthetic cathinones with a very high stimulant effect. I don't know if we've seen it yet. Our toxicologists aren't sure either. I know it's been seen in Florida and Alabama and other areas across the country. Obviously, bath salts were big a couple of years ago, like it's 3 years ago now. We had a really rough summer with them. Lots of aggression, lots of danger. In Austin, attacking paramedics and medics, trying to eat police officers on a golf course, and of course, attacking someone's face and trying to eat their face off. So not very nice stuff. Moving on, synthetic cannabinoids or marijuana. Obviously, marijuana is one of the top abused drugs in the country. It is highly available, but going along the lines of pot, people are trying to make it better or different, get a better high, maybe create some legal ambiguity for themselves. So they've modified the chemical structure to add on different groups, trying to change its chemical properties. K2 and spice are by far the most common names, but like bath salts, there are dozens and dozens of ways to package it and things to call it. This is Ross Sullivan, one of our head toxicologists here at Upstate. And same thing as bath salts. They're packaged, they're sprayed with drugs, and they're distributed, most probably coming from China, we think, but I've not seen proof of that. The reason I'm kind of doing this talk today is, at least here in Syracuse, and I believe in New York City, we've had a real spike in synthetic marijuana cases, which has gotten completely dangerous and dangerous for the people who are smoking it, dangerous for our firefighters and medics, and dangerous for our ED personnel. For the past couple of weeks, we've seen about 15 to 20 patients per day. I think it was 2 Wednesdays ago, I worked an overnight shift, and we had 15 patients who had either been signed out to me or waiting for a metabolized and wake up, or who came in fighting with police, EMS, and my staff. We don't exactly know what the difference is or what the change is. Our toxicologists are trying to figure that out still. They think it must be either a new type of synthetic marijuana, an old type with a contamination in it, or one thought has been they mixed synthetic cannabinoids with synthetic cathinones. So trying to mixing your high together, and it's not going well. People are abusing it like crazy in this area. My favorite patient recently was one who was admitted the night before I came on for a 4 p.m. shift. A patient was there from the night before and left about 4:30 after I got there, and he was back by 7 p.m. high as a kite, and was probably going to spend the night again. So it's a large issue in this area. We've seen 2 types of this new spike in our area. We don't have names for them, just kind of defining them as type 1 and type 2. Type 1 being more comatose, more lethargic, bradycardic, hypotensive. They do get very agitated with stimulation. So if a nurse walks in the room, a med student goes to examine the patient, they sit up and moan and scream and try to hurt people. Usually just 5 or 10 milligrams of Versed are highly effective. And often they're intubated for airway protection and sedation, over sedation with the Versed. As compared to them, there's type 2. We've seen this new spike, tachycardic, hypertensive, super aggressive, large pupils, maybe some seizures. And these are guys we were given 45, 50 milligrams of midazolam to, and often intubating just to put propofol or high-dose Versed or to paralyze the patient because they're so dangerous to themselves and the staff. Going back to what causes excited delirium, number 2 reason would be psychiatric disease. 1 is proven by history. What causes it from the psych perspective? We're not sure if it's either untreated disease, exacerbation of untreated disease, or folks who suddenly stop their medicines. And why would stopping the medicines cause a problem? Either it's a withdrawal from whatever antipsychotic they're on, they have some sort of adaptation to the medication they've been taking for years, they suddenly stop it, and things get much worse. Or they simply stop their medication, and whatever schizophrenia, mania you would have seen just reemerges and is just more significant than when it was treated. We don't have a good reason for any, or we don't have a good explanation for these besides saying psychiatric disease and stopping medications can lead to excited delirium. One thing we always have to keep in mind, especially for us, when we're seeing high volumes of patients with the same thing over and over again, we have to maintain a very high suspicion for a medical or trauma or another drug problem causing these changes in behavior. Obviously, medical problems from infections, hypoglycemia, or other medications can cause these problems. Head trauma, it is hard to know. These folks who come in who are so combative and so out of control to know exactly what happened to them. But a isolated head trauma may also be a cause. Don't forget hypoxia. At least for me, one of my classic patients when I was training was a 19-year-old basketball player who came into the Children's Hospital of Pittsburgh. People at the basketball court told the medics that the kid had been doing drugs. The kid came in. He was combative, flailing around, not responsive to commands. The medics had believed what the bystanders told them. They restrained the patient as best they could. They could not get vitals because the patient was so combative. We got him into the room finally, was combative with me and my staff, and finally got vital signs in the patients and found out he had a pulse ox in the 50s, heart rate in the 40s or 50s. Mom came in, said he had bad asthma, and on exam he had almost no breath sounds. Ended up being a severe asthma attack, leading to hypoxia in a 19-year-old kid who otherwise looked healthy. He made it. We got intubated, got to the ICU, and discharged 4 or 5 days later. But hopefully, it's the last time I'll ever be fooled by asthma exacerbation parading as drug overdose. But you have to be concerned by that, or keep an open mind. Look for other things causing this excited delirium. So how do we manage these cases? I think the most important thing is protect your team. Everyone from firefighters and EMS through the techs, nurses, and other doctors and residents. These folks are violent, and you gotta watch out for your team. Make sure they're safe with these patients, and protect the patient as well. It can be hard sometimes to continue to care for your patients when you have 15, 20 patients who are all swinging at you, trying to bite your nurses, and being unkind people. But we got to keep in mind they're people and they're patients and need our help, and that can be hard to find in yourself sometimes. But as I'm on my residents on a regular basis, it's important to help our folks. And the best way to help them is to diagnose and manage them properly. And this is kind of what it looks like when people come into my ER with excited delirium. There's often a officer and a nurse on each arm, each leg, someone laying across the belly, someone across the head trying to hold the face to one side so the patient isn't spitting at us or trying to bite someone. And I find it be kind of a scary few moments when patients first roll in off an ambulance and they're barely contained, and try to move them from a stretcher, from a EMS gurney to one of our stretchers. It can be a pretty daunting process, and you have to be very careful and control your staff to make sure everyone's safe before you do that. I'm going to steal acronym RODEOs. Obviously, how do we manage these folks? Restraint, oxygen, check their glucose, do a thorough, proper exam of these folks, watch them and do serial exams, and make sure you're not missing something. For restraint, I kind of think there's 3 kinds. There's physical. Obviously, putting hands on the patient and keeping them from hurting themselves, hurting others is highly important. It should be temporary, though. It's not a long-term solution. We can't leave our patients fighting on stretchers against restraints. It's not good for them, not good for our staff. Don't want to use anything that gets progressively tighter. You don't want to cause ischemia of a limb or a hand or a foot. Do use your team together and coordinate, communicate who's doing what, and just be slow and careful. It is nice to say you can back away if you don't have the resources to confront someone. I don't think that's quite as true in the ER. There's too many people around not to confront these patients. In a pre-hospital setting, if you have space, kind of like what we saw with Steve earlier, you can give them some space to do what they're going to do until you have enough manpower and enough help to control the patient properly. You don't want to be going one-on-one with these patients because we're probably going to lose. Obviously, the best thing as soon as you get physical control is chemical control. And I don't care if it's IV, IO, IN, or a blow dart, which we're still working on patenting. But you need to give them some medications to calm them down. Benzos are by far the most easy to use and most frequent we use. We're using Versed in our department, fast acting, give 5 or 10 milligrams IM, and about half the time it seems it works very well. They may need some higher doses sometimes. Antipsychotics have been proposed as potential uses for excited delirium. At least in our region, they're not available pre-hospital. I don't use them myself. There could be a concern with prolonging the QTC if they have that in their EKG and leading to a VTAC or VFib. And some of them may lower seizure thresholds, take a little longer to act. So not first-line drugs, and even with our past 2 weeks of going through our spike epidemic, I haven't used any myself. Ketamine, increasingly used, is one of my new best friends. I've enjoyed using it on my patients because it works well, works rapidly, and can control our patients very well. I'll be honest, I'm still using midazolam most often. I know some of my partners have used ketamine with good success, and there's been anecdotes from other facilities that ketamine works well. And kind of the ultimate sedation is kind of intubation. Either if you have those type 1 patients are real comatose and they can't protect their own airway, or they're so combative that you use higher and higher and higher doses of sedatives without any effect, it may be time to intubate these patients. Or either paralysis or ongoing sedation will control the patient safely. Should we hyperventilate these folks? Be aware of it. If they have a metabolic acidosis, obviously you don't want to put your rate at 8 or 10, causing uncompensated metabolic acidosis. So obviously you want to use your end-tidal CO2 monitor to see where they're at and make sure you're not causing worsening acidosis. Once they are intubated, you can use high dose sedation. I know recently, my last trip on Sunday, we had a very tough patient who was on both propofol and midazolam. Wasn't being managed by myself. He has been signed out as being going to the ICU and ended up the sedation. The MICU staff couldn't take the patient to MICU yet, so they're trying to manage the sedation over the phone with my nurses. And the patient came out of sedation, began thrashing around, and actually lost his tube. And the tube came dislodged, which led to a kerfluffle trying to get the patient intubated again. So just be aware their needs for sedation may fluctuate, and you have to be very careful not to let them get too light because it causes damage, causes problems for the patient. Obviously, in your examination, a good physical exam, watch out for head trauma, watch out for signs of trauma. These folks are putting their hands through walls, they're running into things, hurting other people. Would not be surprising if anyone has a serious injury. If you can't find it on your first exam, obviously as they're waking up, repeat exams are crucial. EKGs we're doing a lot of. I have not seen any concerning EKGs myself in the past couple of weeks with our spike epidemic, but we should keep doing it and watch for those folks with long QTCs, watch for folks with EKG changes to make sure we're not missing something that will get more dangerous if they get sicker. Obviously, a CK level for rhabdo, maybe a urine for myoglobin, troponins, and metabolic panels to see how their acidosis and electrolytes are doing. Vast majority of the time, we just observe them, keep them in the ER, and we call it metabolized to freedom. Once the drugs wear off, they wake up, they walk around, they get their boxed lunch and some drink, out the door they go. I don't have numbers, but we are admitting, it feels like 5 or 10% of folks, mostly to the MICU if they require intubation. Obviously, serial reassessments, don't let them sit for hours and hours and hours without someone watching them. Go back in there and look at them and make sure they're okay. Cooling may also be necessary for these folks if they're hyperthermic. We're putting lots of urinary manometers into folks to follow their core temperatures. Sedation obviously stops the muscle twitching, stops their fight, and helps them cool off. Do you need paralysis? For my one patient the other day, I did, but you have to worry about seizures, so it's not really a good long-term option. Fluids, cold packs, cooling blankets, of course, should also be used. For my pre-hospital providers, there are a few things we've been trying to keep aware of. Proper training is crucial. You can recognize these folks from across the parking lot or across the road pretty easily. Obviously, coordination of care between fire, EMS, and police is critical, and knowing how to use restraints, how to secure folks to the backboard properly, how to immobilize them. Obviously, hog tying patients is not a good idea. It's been that way for decades. But so on their backs, with their arms at their sides, either using devices to kind of give them a big bear hug so they can't move out of place, or handcuffs or leather restraints. And having medical control available to help the medics control these people. Make sure your base commanders are able to to know their protocols for what the medics are facing and be able to give them orders to help keep the patient and themselves safe. We recognized we had a big problem in our protocol about, I did an overnight shift on Wednesday. I think it was Monday or Tuesday when 2 weeks ago when this spike thing just took off. It's really within 24 hours we saw a huge bump in these. And by Thursday morning, it was pretty obvious our standing protocol was not working. Our protocol had been, for ultimate mental status, paramedics were to call med control for an order for either Haldol or midazolam. And we had a problem where when they were on scene, police or fire, someone was restraining the patient, and they had to wait, especially if they got involved in patient care, to get the patient secured so they could then call in to request the order. And that was taking time. So you're increasing the time of physical restraint until chemical restraint. It can be hard to talk to our crews sometimes with the growling and the yelling in the background. And we did have 2 paramedics hurt. I think one was bit and one had I don't know if it's a strain or a contusion, because there's a delay in chemical restraint. I do give credit to the New York State Bureau of EMS. Within 2 days, myself, Dan Olson, the regional director, Lee Burns, the state EMS director, recognized the protocol was not adequate, and they extended us an emergency protocol change for midazolam 10 IM or 5 IV as a standing order, which I have not heard any more stats in the past week. I apologize, but that's at least the better idea, earlier chemical restraint for these patients. And for medical directors, we have to do close chart review to follow these cases and watch for complications and submit them to the state. So wherever you are in the country, make sure your protocols are adapted to address these patients. Moving ahead a little bit. So that's excited delirium in a nutshell. One other part of this is kind of sudden in custody death. There is situations where you have these excited delirium patients who die. A couple in our area, 2 or 3 years ago, there was a very unfortunate case of a woman who took bath salts, lived in an upstairs apartment with outside staircase, and was beaten up on her 3-year-old son, actually threw him down the staircase. And I think she followed him and was trying to hurt him further outside. Neighbors came out, took the kid, and ran away until police got there. Police tried to give her verbal commands. She would not comply, used tasers to get compliance, and then she suddenly died afterwards. So sudden custody death after police arrival and begin restraint. We had another one here several years ago. I think it was 2010. A gentleman by the name of Mr. Panay died in the Onondaga County Jail or the Justice Center. There's video online I couldn't pull off. I apologize. But he was using cocaine. Police arrested him because of past warrants for his arrest and for his drug abuse. Took him to the jail, put him into a proper cell, and if you can pull up his video online, he does have about 6 or 7 gentlemen on him, kind of like we have in the ER, with a spit mask over his face, a knee on his back, controlling his limbs, and the officers are trying to extricate themselves from the room. They've got him there. He was previously restrained. They put him in the room, take off restraints, and they back out of the room. And as soon as, well, I shouldn't say as soon as, within a couple minutes of them removing restraints and coming out of the room, apparently he laid on the floor, became very still. And I'm not sure how long he was on the floor for before a nurse got to him, found he was in cardiac arrest, began CPR. Rural Metro, our local EMS agency, came to pick him up, and he died. Was pronounced dead at the ER later. So he was another example of in-custody death. So I think we have to keep a law enforcement perspective on this. Obviously, I think this is a tough position for our officers to be in. Obviously, EMS is not, well, at least here, EMS is not involved in restraining patients primarily. We leave that to police officers, and they come up on patients who are irrational and combative. They're doing silly things that are putting themselves at risk, whether it would be like Steve or the gentleman from Appleton, who are trying to hurt themselves, a danger to officers, and a danger to the community. And the unfortunate fact is they must be subdued. I guess the ultimate question is, if you had these patients, you put them out in the field somewhere in Lancaster, Pennsylvania, let them run around for a while, what would happen? Would the medication wear off and they'd all be fine? Maybe. But it doesn't really happen in a city environment. If they're running out in traffic, they're going to hurt someone or get themselves hurt. So it's up to the police to get these folks and restrain them. There's a very clear progression of sudden custody death. They have excited delirium symptoms. They're fighting. Police and others get involved, apply restraint to the patient, gain control. Then sometimes you see patients say they're short of breath. Listening to the news reports for the past few years, there was a case in California. Patient was restrained, handcuffed, put in the back of a police vehicle, and you can hear the patient on the tape saying, "I can't breathe, I can't breathe, I can't breathe, I can't breathe." And then they go suddenly quiet, and there's nothing. You don't fight. At some point, someone checks a pulse and finds out they're in either respiratory or cardiac arrest, oftentimes from asystole or just a bad bradycardic rhythm. And then they die. Why do these folks die? Lots of ideas why. Different hypotheses. Catecholamine surge and then drop, so your fight or flight reflexes get kind of screwed up, where you fight and then you rest and then you kind of collapse. Could it be due to hypokalemia from the metabolic acidosis? These folks do have pHs in the 6s sometimes. Could it be due to heart conditions? Not every patient with excited delirium who's restrained dies. So those who do die, is there some sort of heart damage, pre-existing condition? Do they have a long QT syndrome we don't see because they die in the field before they get to the hospital? Is it some sort of psych problem or neurochemical problem? Not sure. I'll be honest, for myself, the idea of uncompensated acidosis is kind of attractive. Obviously, these folks are fighting, using so much energy, they can put themselves into a lactic acidosis or a metabolic acidosis, which while they're running around, perhaps they can compensate for. They breathe off CO2, so take their high hydrogen ions, shift the buffering curve this way and blow off the CO2, so they have a compensatory respiratory alkalosis trying to balance out their low pHs. and then come police or all others to help restrain the patient. And if, as we'll see in a video here soon, and then as you've seen previously, oftentimes it involves physical force, pushing them to the ground, putting a knee on their back, a knee on their neck, or somehow pushing on their chest. Or if you're using a taser, the taser causes muscle contractions. If you apply the taser several times to the chest and they can't move their chest, they can't breathe, perhaps they can't compensate their CO2 being blown off, the curve can't buffer itself, and you have uncompensated metabolic acidosis. So whether you have respiratory acidosis or an uncompensated metabolic acidosis, I'm not sure which, but that leads to cardiovascular collapse. It seems like an attractive theory to me. I don't think anyone has a clear hold on this yet. This seems most attractive. We'll see what the research bears out in the future. How can we prevent these deaths? Most often, minimize the struggle. I think the good example from Appleton you saw was a police officer came in, saw the patient. Fortunately, in his situation, the patient wasn't combative, wasn't fighting with him, and laid down by himself. But then he waited, watched the patient, waited for backup, waited for EMS. So when they approached the patient, they approached him, applied physical restraint, and shortly thereafter applied chemical restraint. I don't think I included that in the video set, but they did give the patient Versed in that situation. So having someone there to apply restraint all at the same time, getting EMS there early from a police perspective, and having someone monitor the patient. Having one person's job not to be involved in the restraint and the medication administration, but just to monitor the patient. Watch his breathing, watch his pulse, watch his vital signs, and watch for any sign of decompensation to try to intervene before they go into arrest. Oops. So cardiac monitoring, watch respirations. If they do have this really bad excited delirium, expect that decompensation. Keep them on a cardiac monitor. Check their end-tidal CO2. Get them to the hospital prudently. And if they do arrest, early effective CPR. I think we've been pushing and hitting home on early effective CPR for cardiac arrests a lot for the ED and our pre-hospital providers, maybe not so much for our police force. I'll show you an example here in a second. So I'm going to end with an example of sudden in custody death. In October 2005, there was a gentleman by the name of Donald Lewis who was found by the side of a road. So I'll start playing. I've kind of highlighted key points. This takes about 10 minutes, I believe. And we'll go through each one.
6-7 out with the signal 2600 block of 45th Street.
Oh, just to add, this unfortunate incident, an episode of Cops was being filmed with this police department. So the images you have are from the Cops crew following this police officer. And it never aired on TV, but they became released for training purposes.
What's up, buddy?
White male, no shirt,
Lay down. Lay down. What's going on, bro? Who?
So naked,
You smoke, man.
I don't do nothing. Oh, Lord.
Hey, do me a
not
favor.
right in the head.
Relax.
Please.
Okay, I'll help you.
Oh, my God.
Hey,
Relax.
relax.
I want nothing lower now. I'm sorry.
Relax. Get on the ground.
So not listening to instructions.
Get on the ground.
I'm on the ground. Oh,
Stay
Lord.
there. Hey, stay like that. Come
Come
here,
here. Go
dude.
ahead. Oh, all right.
He goes from the side of the road.
Stop. Hold on, the cars are gonna.
So he walks out into the road, danger to himself, danger to the population. The person who's in the car there in front of, fortunately, stopped, saw the police officer's car was stopped. So somewhere now, so at 4:50 in the morning, they begin applying restraint to the patient to gain compliance. And you can tell this officer is probably 6'4", and a very, very large man, as we'll see later in the video. This gentleman he's restraining is obviously older, not in very good physical shape, and is fighting very, very hard, to the point where this officer, who's obviously in much better shape, is having a hard time controlling him for a while. So secondary help arrives. I think the other officer has his left knee behind the patient's neck.
Okay, just relax.
I got no fucking. Start the medics. Start medics. Let's go for it.
So that's important. So here we are at 4:48 in the morning. So within 3 minutes, this kind of escalated from just stopping the patient on the side of the road to him walking out in traffic to officers applying restraint. And you noticed they called for EMS early. So within 3 minutes, they're already calling for paramedics to come help him, because they recognize this is not just a police matter, but a medical patient is sick. He's overdosed on something. Oops.
I'm Officer Shaw. I'm gonna help you. You gotta help me.
What's your name? Hey, now.
Yeah, we're just trying to get the page here.
Hold on one second. I got to slide. Here we go. I missed a slide. I apologize. So in the road still.
1, 2, 3.
So he's handcuffed behind his back. 3 officers kind of drag him to the edge.
Right there.
Patient's trying to eat the officer's foot.
Sit up. You're a dummy. Sit up.
To give the officer credit, they're trying not to apply pressure to his back. They're trying to have him sit up. They're trying not to push down his chest. I think this must be a supervisor who arrives with a taser.
You get him up.
Hey, you need to chill out. Sit up. Sit up on your butt, man.
So they're trying to get him up off the ground to a better position. So they're trying to get him up off the ground. Obviously, being on his stomach is not a very safe position. I don't know if it's part of their protocol or if it's a common police procedure. I'm not sure. But at least they're trying to get him up away from a dangerous position. That being said, it changes.
Officer Shaw, I'm gonna help you. You gotta help me.
What's your name? Hey, now.
Yeah, we're just trying to get the page here.
So you see how hard the officers are working. They're short of breath and they're all sweaty. You can imagine this guy and how hard he's working too.
You're lying. I have jump.
Right, get your gloves on.
No close. I'm lost. Get off his eyes.
Keep still, right?
Oh, please, the door.
Oh, we got him on already.
We already have one. You didn't have
Oh,
one.
you're killing me.
But I couldn't get
So they changed their restraint right now.
Yeah, that would be good.
So they begin to hog tie him. Shoulders to the back, or sorry, knee to the back, hog tied.
Stop it.
And they actually lift his feet and his pelvis off the ground, kind of forcing his chest into the ground. If you notice right now, he's still breathing. So a much different situation from the last slide where they're trying to sit him up, not restrain him, to this slide where now they're applying more and more restraints. So you can see here, we started over again. So this is not that long after the last slide where he was heaving. Now look at him now. He's not fighting. He's not taking breaths. I would say the arrest probably begins right there. 20 seconds later.
So I think we've reached the state of unconsciousness here, gentlemen. Yeah, I think we've reached the state of unconsciousness.
So they recognize something bad has happened.
We gotta get him back up on
Yeah,
his butt.
check him. Yeah.
Keep in mind, police officers are not medics.
We've reached the state of unconsciousness.
Get the bag. Get the
So
bag.
trying to
I'm telling you right now.
get the bag, so get an ambu bag, at least they have.
Start the medics here.
You already did. Hey.
It's been 7 minutes. Medics are still en route. Not arousable.
Check your foothold. Make sure
Get your,
he's breathing. Undo the hobble if you have to.
I'm trying to. But I can't get
Still hogtied.
Back going again.
It's got a pulse.
Okay. All right, he's probably going to stay unconscious, so let's go ahead and undo the hobble. If we have to hobble and get the hobble.
I need a light.
Okay. So he has a pulse. They're trying to figure out what they're doing.
Sit him up.
They finally do get him sitting up because he's not fighting anymore.
Yeah, hey, don't take that hobble. Hold on to that hobble.
No oxygen. Look at his airway right there. So they're trying to do rescue breaths
Get him here.
with his chin on his chest. At least they know enough to try to get his airway open. I'm not sure why they have him sitting up. I guess it's probably because he's hogtied and has his hands behind his back still.
You're making it, yes.
Ready to have calls on him?
I can't tell, so.
So this is about 8 minutes after the call started. People are not still, they're feeling pulses, not sure if they have one. They decide to go for CPR.
Okay.
Patient's obviously flaccid.
Get the cuffs off.
And it takes about
Somebody give me a key.
45 seconds by the time they decide he's in cardiac arrest to begin CPR.
Get the one off. We'll flip him over on his back. We'll work him.
Yep.
And then somebody get that other cuff off.
Got it.
So he can't hit us with it when he wakes up.
That's it. Let's do this thing, guys.
Handcuffs.
Tilt it back.
So
Get it
54:30.
over in his mouth. Get it out of his mouth.
5 and 2. 5 and 2.
So this is 2005, and to be honest, I can't remember my AHA protocols, what the
Four, five. Breathe twice.
respirations to compressions were. I'm guessing 5 to 2.
3, 4, 5. Breathe. 1, 2, 3, 4, 5. Breathe. 1, 2, 3, 4, 5. Breathe.
Check for signs of life.
So only got about 30 seconds of CPR
Yeah, we got
before
it.
they stop,
We got a pulse.
Keep going.
but they do have a spontaneous return of circulation.
Is he breathing?
Stop this for a second.
Check. Check his airway. Listen. Put your head down there and listen.
There you go. Get down there.
So kind of the old look, listen, and feel, see if they're breathing.
Keep it back. Keep bagging. Rescue breathing.
Take your time. A little slower.
So she does say, I'm not sure who she is, but she kind of takes charge of the medical part. I think she's an officer, says breathe slower. Again, metabolic acidosis, maybe some hyperventilation. But does he have a head injury? I'm not sure what the right answer is. I think I have my timestamp wrong. They do have a pulse again. Right about now.
He's got a pulse.
He's got a
Let's
pulse.
keep the breathing going.
You getting the chest fries on him? Put the bag.
That's
Put the
right.
flies on him? Okay.
So skipping ahead, so we're at 4:55. A couple minutes later, EMS arrives.
I should be doing chest breathing. No, he's got a pulse.
They're trying to figure out if they should do CPR or not.
I got it on his neck. It's there. You got it still?
You're feeling the air go in and out. What's it doing?
So it's 4:57. EMS arrives. It's going to skip forward here in a second.
No, I'm not. We didn't have one, and we had one, and
So just skipping ahead, right about here. So about 4 minutes after I started, begin CPR. They do mention he has a pulse in the 40s, so I'm unclear if it's in PEA. So see how big that guy is compared to everyone else at the scene? It's huge. You can see the quality of CPR. So he's going, what, 50 times a minute with one hand here, trying to do his monitor and CPR at the same time. Here's a gentleman right behind him with an intubation tube. Then we kind of lose the team here. So I think they're trying intubation here. They pause CPR in about 20 seconds. And we'll skip ahead. That's kind of towards the end of the video.
Literally went that fast. It was unbelievable.
I pulled up, and he's standing in the middle of the street, jumping up and down, waving his arms, and he's sweating.
Yeah.
The first thing I asked him was, like, good, what kind of dope you doing? Are you all right? And then he goes running across the road, and his car's coming. So I get the car.
So we'll swing down to the scene again here.
Are you kidding me?
So we're a couple minutes out from starting intubation. He's trying to sternal rub. Gentleman's chill on his knees trying to intubate. No CPR.
Oh, I didn't even know that was a caller.
So this is the officer who responded first, walks away.
Yeah.
So I put in there, I wonder what his mental health or mental state is like at that point in time. Walking back to his vehicle, I'm not sure what happens afterwards. But obviously, within 15 minutes, it goes from perhaps a routine stop to being the death of a person, which he restrained and then ultimately died. It did lead to a lawsuit between the gentleman's family and the city. I forget off the top of my head what the result was, but I think there was some findings. And it kind of shows you how fluid these situations are. How quick they can change from being a stop to being someone decompensating. You can see how the restraint was applied. Obviously, the hog tie we mentioned before should never be used, should not be kept under their chest. Some positional asphyxia probably does not help with the metabolic acidosis and the upset delirium. Unlike the Appleton case where they had early EMS involvement with the restraint, they didn't have EMS on scene for approximately 9-10 minutes, and unfortunately had a very different patient outcome. So that's the talk about excited delirium and sudden in custody death. Talked about excited delirium, causes, treatments, keeping your team safe, and then talked about in custody death. Keeping your team safe, watch the patient, be very cautious how police are restraining the patient, watch the patient, and get involved early if at all possible, and you can do so safely. So that's my end of my presentation. If anyone has any questions, you can text me or I'll unmute people. Give you a few seconds. Nothing.
Hello?
Hello?
Yes, hi. I was trying to log in to watch, and I was unable to do so for whatever technical reasons. Will this lecture be available to view?
Yes, actually. Let me see if I can pull it up here for people. We actually started a website. If you search for Upstate EMS Fellowship, we are one of the tabs underneath application and what we do. EMS Medicine Live is right there with a copy of the slides and a copy of the presentation. And also on Facebook, EMS Medicine Live as a site. And when we link our YouTube channel up to Facebook so you can watch any of the videos there as well.
Okay, great.
Great. Anything else? No? Good. All right. Well, thank you for attending. I hope this was useful. If you have any feedback, I always want to hear about it. Feel free to contact us. If you have any topics you want to discuss, if you want to get involved in presenting a case or a good topic, let us know. Otherwise, we'll see you next month. We're still working on the topic. In 2 months, we have Chris Martingill from the University of Pittsburgh giving flight physiology as it relates to air medicine. We do have Jeremy Cushman from Rochester doing a case of a trapped patient in a couple more months. But I'd like to get more folks involved if you're willing. So with that, thank you very much.
Thank you.